Got it in the back.
Yeah,
We're good.
okay,
Yeah.
cool.
Perfect.
All right. Were you,
Are you
Yeah.
using projectors?
are they not on? I'm sorry, I was not first.
Thank you.
Oh.
Like when you did, yeah.
Okay, so for everyone who doesn't know me, my name is Gretka, and I'm going to be talking to you about return to play for competitive cheerleader post-concussion. So what is a concussion? It is a functional injury, meaning it's not going to show up on an MRI or a CT scan. It's a neurometabolic cascade of events. So there is a release of neurotransmitters leading to a widespread dysregulation and ion imbalances in the brain. The brain then goes into a hypermetabolic state to correct that ion imbalance. And the imbalance can lead to an extended period of altered glucose utilization. Usually those metabolic processes are restored to normal within 7 to 10 days. In a healthy, normal brain, the cerebral blood flow is coupled with metabolic activity, meaning if you have increased metabolic activity, you have increased blood flow. But with a mild traumatic brain injury, such as a concussion, a coupled mechanism can be impaired, leading to secondary injury and concussion-like symptoms, which are consistent with the areas of hypoperfusion. At this time, the brain has increased vulnerability to trauma due to its inability to regulate pressure within the cranial cavity. Therefore, if a person sustains a concussion during this time period, they can have further damage, such as second impact syndrome. According to Move Forward PT Concussion Guide, post-concussion syndrome can be diagnosed when a patient develops 3 of the following symptoms within 4 weeks: headaches, dizziness, fatigue, irritability, impaired sleep, impaired memory, impaired concentration, and impaired tolerance for stress or emotional situations. Studies have shown an inconsistency with the number of patients who can develop post-concussion syndrome following a brain injury. This number from my research ranged from as little as 10% to as many as 30%. So these are some of the predictive factors of post-concussion syndrome. They include female gender, pre-injury anxiety or depression, acute post-traumatic stress, about a week post-injury, emotion-based symptom reporting and coping style, specifically in children, and a history of anxiety sensitivity, which is an abnormal, fearful response of pain and can influence how an individual perceives pain. Condor et al. Noted that the best predictive factor of PCS at 3 and 6 months post-injury is the all or nothing attitude, which means that when an individual is feeling good, they are overly active. And then when they are having symptoms, they take an extensive rest period. So the purpose of this case study is to understand the importance of differential diagnosis and the evaluation process for a patient presenting with headaches after a head injury, and to evaluate the effectiveness of using the return to play protocol for a patient with post-concussion syndrome. So a little bit about the patient. She was a 12-year-old female cheerleader with a chief complaint of headaches and dizziness with head and eye motion. She has had trouble participating in class, specifically for sport, due to light sensitivity as well as rapid eye movements causing headaches and dizziness. She reports the onset of her accident was in October of 2016, following an accident in cheerleading practice. She was a flyer on top of a stunt when she fell backwards and hit her head on the ground. She denied any memory loss, but she did momentarily lose consciousness. Her mother did report that she has been having some anxiety and emotional issues since the accident. However, no issues with sleeping that she was aware of. She first came to the Center for Sports Therapy about a month after her initial injury. She was receiving concurrent treatment at the Brooks Balance Center for vestibular and balance-related deficits, and was referred to the Center for Sports Therapy to evaluate and treat her headache symptoms in relation to returning to sport. So her subjective examination, she reported her pain as a constant thumping and fogginess in the back of her head. Current was a 4 out of 10. At best, it was a 1 out of 10, and at worst, it was a 10 out of 10. Her aggravating factors included squinting, looking at bright lights in the computer lab, and just bright lights in general. The patient's mother reported her headache was often so severe at times that she would have to come to school and take her home. Closing her eyes and sitting in the dark helped relieve her symptoms, and she reported that her symptoms would last anywhere between 1 and 20 minutes, depending on the activity that she was involved in. So following the history and the subjective exam, headache secondary to concussion, cervicogenic headache, and headache related to a neurological red flag condition were my hypotheses in order of likelihood. At this point, she presented with no concerning red flags or anything alarming in her past medical history. For the physical exam, my goal was to eliminate any neurological causes of headaches that would require referral to another medical professional, as well as rule out any other musculoskeletal causes of headaches related to the cervical spine. According to the Move Forward PT Guide to Concussions, some potential red flags to keep in mind during the rest of the evaluation included any signs of cervical instability or fracture, and then any abnormal neurologic signs such as spasticity, gait ataxia, visual or speech impediments, and prolonged loss of consciousness, as well as seizures. For the physical exam, the components listed on the screen here were the most significant. Cervical range of motion was within normal limits. She did have some mild muscle guarding, however, no symptom provocation or reproduction with any cervical motion or palpation to the surrounding area. Cranial nerves were grossly intact. She did demonstrate some headache and dizziness with saccades, convergence, and the H test for cranial nerve 3. However, no abnormal findings such as nystagmus or overshooting. The flexion rotation test was negative for symptom reproduction or provocation bilaterally. She was below norms for the cervical joint position error test and was unable to hold the deep neck flexor endurance test for greater than 11 seconds without compensating from the SCM. Since she was being seen for more in-depth vestibular and balance deficits at the Brooks Balance Center, we conducted the VOMS assessment just to get a basic vestibular ocular function. So a picture on the screen here is the vestibular ocular motor screening. It's a comprehensive assessment of the vestibular ocular system post mild traumatic brain injury, unlike other common post-concussion assessments like the SCAT-3 or the impact. It assesses 5 areas of the vestibular ocular systems, including smooth pursuits, saccades, convergence, VOR, and visual motion sensitivity. It integrates vision and balance, as well as movement, and is a long-term predictor of success following a sport-related concussion. Some factors, including the visual impairments, dizziness, and fogginess, are some that are associated with prolonged recovery following a sport-related concussion. However, outside of the headaches and dizziness, there were no abnormal findings, including nystagmus and overshooting with the vestibular ocular test. So at this point, we did consider her VOMS testing a significant positive finding. However, we didn't rely on it too heavily due to the ease of her symptom provocation throughout the evaluation. So diagnosis of a concussion can be difficult just due to the variety of symptoms a patient can present with. Headaches and dizziness are the most common, so we had to rule out the cervicogenic or neurologic causes. Based on cranial nerve screen and history, potential neurological red flags were ruled out at this point, as well as cervicogenic headache was also ruled out due to normal cervical range of motion and musculature, no changes in symptoms based on neck position, as well as a negative flexion rotation test. Based on the ICF model, her health condition was diagnosed as a concussion, with poor deep neck flexor endurance and headaches and dizziness with head and eye movements. Her plan of care was initially set to 2 times a week for 8 weeks. However, because of her concurrent treatment at the Brooks Balance Center, she was only able to come 1 time a week. And that was more her mother's preference, and she had after school activities and all that kind of thing she had to be participating with. Her expected outcome was good as opposed to excellent for several reasons. According to the National Athletic Trainers Association position statement, there are several factors that can delay recovery post-concussion, and they include a prolonged loss of consciousness, emotional or sleep disorders, symptoms lasting longer than 10 days, and then being less than 18 years old, which, as you can see, she has several of those. Several studies also suggest that adolescents in general take longer to recover than older athletes. And then in addition, she was unable to completely rest as much as she needed to due to being around exam time in school. Her initial home exercise plan included chin tucks and cervical rotations as tolerated. The main focus here was to introduce cervical rotation at a sub-symptom threshold, just to tolerate some general head movements without that dizziness, as well as chin tucks for deep neck flexor activation without compensation from the SCM. Based on the ICF model mentioned on the previous slide, her goals for therapy were to return to sport and her school activities without headaches. So potentially due to lack of education on the potential risks, there's often social pressure from coaches, peers, even parents to return to sport prematurely, which is why I specifically chose the things you see listed here to educate her on in order to stress the importance of not returning to sport too soon. Both the patient and her mother were educated on her symptoms, as well as the risk of repeated concussions. The patient was additionally educated on resting and participating in sub-symptom cognitive activities. So several studies have shown that participating in an initial period of rest is beneficial just to neurocognitive functioning as well as decreasing some of those symptoms. However, when an athlete who is used to that higher level of physical activity on a regular basis is restricted to complete rest, both physically and cognitively, they can develop secondary issues such as stress or anxiety from missing class, deconditioning, irritability, and even depression. Therefore, studies have also shown that moderate activity is overall the best for neurocognitive function as well as decreasing symptoms. The outcome measures used to assess her progress throughout the plan of care include the patient-specific functional scale, the disability index, and the post-concussion symptom scale. Sorry, I lost it. I actually lost it. Nope, I got it. Just kidding. Okay. She rated 4 out of 10 for her ability to participate in school activities due to headaches and fogginess, as well as a 0 out of 10 to participate in cheerleading at that time. She was 36% impaired according to the Neck Disability Index, with most difficulties relating to her concentration and head positioning. The post-concussion symptom scale, which is pictured on the right of the screen here, rates symptoms from 0 to 6, with the higher the score being, the more severe the symptoms. And she had the most difficulty on this scale with concentrating in the school setting, headaches, fogginess, and dizziness. Additionally, I used the Florida High School Athletic Association Form AT18 to document her progress as she completed each stage of the return to play protocol. So pictured here is a blank copy of the AT18 form return to play protocol. So in general, the patient has to be asymptomatic at rest before they can even start the protocol. As you can see, there are 6 stages: no activity, light aerobic exercise, sport-specific, non-contact training, full contact practice, and then return to full activity. Generally, each stage takes about 24 hours so that the athlete completes the whole protocol roughly about a week. In order to go to the next phase, they have to complete the current stage without symptoms. If they should get symptoms, they have to return back to the previous stage and try again within a 24-hour period. Prior to starting PT, however, she was not asymptomatic, so we didn't start using this protocol until about week 3. So at week 1, she reported no change in her symptoms since initial evaluation. However, she was able to perform her at-home exercises without any issues or any increased symptoms. Due to coming 1 time a week, she was educated to keep performing those at home just so we can maintain some higher level activities in the clinic. The goals for our treatments were to start with sub-symptom habituation exercises. Therefore, we began with basic laser eye movements between targets. She had a laser on her head, maintaining at a target just for some cervical stability, and she had to maintain a chin tuck neutral position. After establishing a tolerable distance, her targets were set at 160 centimeters apart, and then to be as objective as possible, a metronome was used to pace her eye movements. With all of these exercises, her headache would mildly increase. However, upon stopping, it would return to baseline. At week 2, she reported some mild headaches with some school activities, but at that point, I contributed those mainly to being exam time and having to really focus and concentrate and do a lot of reading. However, overall, her symptoms were improving. They were less severe, they were less frequent, and her mother noticed that she wasn't as irritable and stressful. We continued with the laser eye movements between targets, and were able to increase the distance as well as the speed and direction without increased symptoms. We attempted some close range convergence activities. However, she didn't tolerate these very well as her symptoms increased drastically. So this activity was stopped and replaced with a single leg static stance with a trampoline ball toss to mimic convergence as she followed the ball down and followed the ball back up. Additionally, a single leg stance on foam with a ball toss while looking between different target objects was added to mimic that instability, being in a flying position, while continuing to challenge her ability to tolerate those eye movements. So at this point, we were beginning to transition from lower level habituation exercises to more functional, higher level activities. So at week 3, she had been asymptomatic at rest since her last visit, so we were able to start advancing her on that protocol. She was eager to return to her sport at this point because she had been asymptomatic with rest and with some general activity. Therefore, our goal for this session was to determine what stage roughly she was at on the protocol, and then continue challenging her with higher level functional activities. So the intervention started with some light aerobic exercise on the treadmill, which she completed without any problems. She progressed to sport-specific exercises, including trampoline jumps with head turns for increased difficulty. They were performed without eye fixation in order to be as close as possible to what she would be doing while she was cheerleading. To simulate non-contact drill training, I had her perform trampoline jumps ending with a static stance landing, such as a toe touch jump or a scorpion landing, which you can see pictured here on the right. She was also able to perform all of those without any issues. Outside of general fatigue, she experienced no symptoms. So at this point, we were running out of time in the session. However, her estimated stage was around stage 4, which was non-contact drill training of the return to play protocol. She was educated to continue doing her daily activities as long as she experienced no symptoms. And due to her practices being several hours in length, she was educated she could start to attend just to get used to the general bright lights, exposure to the loud cheers, and just tolerate being in that setting for several hours at a time. However, she was not to participate in practice until we attempted more higher level activities. So at week 4, she had no symptoms at rest or with activity. It was hard at this point to mimic some of those higher level cheerleading activities like a stunt, because I can't throw up in the air. However, in order to challenge her as much as possible, her interventions include a series of jumps, handstand transfers, and mat tumbling. She completed all of those without any symptoms of any kind, and we sent the completed 8218 form to her physician and educated her to attempt a slow return to cheerleading and to contact us if she had any issues. So the discharge criteria were set to incorporate her goals as well as her impairments. They included being asymptomatic at rest and with activity, being able to participate in school activity without symptoms, and then completing the return to play protocol, verifying her ability to perform sport-related activities without symptoms. So there are several limitations with this case. I did not research post-concussive syndrome until after the patient was discharged, so I was not able to apply anything I learned about post-concussive syndrome to her treatment sessions. Looking back, based on just her duration of her symptoms and her type of symptoms, I do believe she was within that 10 to 30% of patients who do develop PCS post-head injury. As I mentioned previously, she was receiving concurrent treatment at the Brooks Balance Center. Therefore, I did not specifically test balance in her initial evaluation. For her final session, I was out sick that day. So I had planned her interventions, however, did not make a note to specifically retest her outcome measures. So at this point, I can only make assumptions on how she would have scored based on her subjective reporting during the last couple weeks. And then lastly, I believe that there were some difficulties with following the return to play protocol. One of the issues I had was applying the protocol to a patient who wasn't seen consistently. I think for this patient, it would have been ideal to see her multiple times a week just to get an idea of how she was responding to the treatment sessions and like the overall stability of her symptoms on a day-to-day basis. So what would I do differently? With guidance, my clinical instructor allowed me to decide if I was going to test her balance or not. And there are a few reasons why I chose not to. Since she was being seen at the Brooks Balance Center, I was able to access all of her documentation. So if I had any concerns, I could go back and look it up. I could also see what they were doing as well as how she responded to each of those sessions. In addition to trusting the other therapists, I didn't want to spend any additional time focusing on balance, and she was receiving specific treatment for those, especially since she was only coming to our clinic one time a week. And then thinking back, if I had any skepticism on her balance testing or noticed any outstanding deficits, then I would have followed up with some balance testing of my own, as well as contacting the other physical therapists if I did have questions. And then lastly, I would like to formally reassess her outcome measures more frequently, as well as ideally seeing her more than one time. These are my references. Any questions? Yes.
How long were her treatment sessions each week?
They were an hour, sometimes an hour and 15 minutes.
How long after her accident was it saw her?
So it was about a month after. So she started at the Brooks Balance Center first, and I think it was that therapist that referred her to us for her headaches.
So now that you've researched post-concussive syndrome, there's kind of different diagnostic categories within that. Which ones do you feel like she fit into? Thinking back to your initial hypothesis and then your intervention that work. Just have some sarcogenic would be one, and then vestibular would be another one.
Yeah.
Do you have a sense of which or both? Or?
I almost want to say a little bit of all three. I think her symptoms started changing a little bit as we progressed. So initially they were more related to head and eye movements, causing her to have that headache, but then towards the end it was just the eye movements. But I think probably more vestibular related than the other two categories, I think.
Did she have any fear avoidance behaviors? I would imagine falling and hitting her head from a set vehicle.
She didn't demonstrate anything that I noticed. She was a little timid in the beginning to start doing some like the jumping on the little trampoline and those kind of things. But I think that was more from she hadn't done anything for so long that she was like, am I allowed to do this? This would hurt me. But once she knew that I was going to stand right there next to her, she was fine. And then she kind of started opening up and it got a lot better.
I think my only other question, sorry, was when you were thinking back to your three hypotheses, you're thinking one might be like a neurologic red flag. What were some thoughts behind what red flag?
So I can remember correctly, I don't think she had an MRI or any kind of imaging. So my concerns for her would have been, is there any bleeding, any swelling going on that's causing her headaches? That's disguising something underlying in there. But she didn't report like blacking out or she didn't have any speech impediments. Nothing changed over her course of treatment. So that was kind of really low on the list after that.
Did you do anything to just say when she was getting better from week like 3 and 4, like she's saying that she's not having any symptoms at rest? Did you do anything to like make sure she wasn't just pushing through and doing it to get back?
Mm-hmm. So at that point, we had developed a pretty good rapport. But her mother was also there with her, and so was her father on occasion. And they were pretty open and honest about what she was doing at home and if she was having anything. And she wasn't doing anything outside of her normal activities and wasn't demonstrating any adverse symptoms to them.